I'm Ken Mandel. I direct the Computational Health Informatics program, and this is a installment in our Landmark Ideas series here in the Landmark Center. And we are going to be talking today with Ricky Bloomfield, who's the Chief Medical Officer at Aura. But before I introduce him further, I want to ask Ricky, why are you wearing two Aura rings?
We're just having that discussion. So you'll see a lot of Aura employees wearing two rings. One is actually attached to our production application that everyone has access to. The other, in this case, my left, is connected to our experimental app where we test new features, software features that you don't have access to yet. So we're always testing, providing feedback ourselves. Best way to learn and to iterate. So that's why I have two. You'll see some more like the craziest ones have like three or four, because they have experimental and production on both iOS and Android and all those fun things. So
Right.
there you go.
So I first became aware of Ricky because I heard that he was working at Duke as a young buck on a system through a programming interface to the electronic health record, create an apps ecosystem at Duke. And that's exactly what we were working on in a project called Smart or Smart on Fire. And so we called up Ricky and said, hey, this would be an amazing way to collaborate. And we've been collaborating in various ways ever since. And when Ricky went off then to Apple from Duke, he along with actually around the same time, two of our team members from here in Chip also went off to Apple. Ricky became the clinical and health informatics lead for Apple. And there was a moment when I thought that everything we were doing to essentially create this apps ecosystem through an interoperable interface to electronic health records called Smart on Fire, I thought it was kind of done because or at least slow down, because people like Ricky and the folks in our team, like Pascal Pfeifner, who's still at Apple, they're not easy to replace. And when you do replace them, it takes years to get someone up to that level, and they're not easy to find. But it actually worked opposite to my fears, and these guys took what had been going on in the open source academic world and turned it into full industrial scale. And so I've been incredibly impressed with Ricky since then, because he proved that he could take something to full system scale. And during that period, every health system connected in such a way that any American with an iPhone essentially could download their data onto the iPhone in a standardized format. And also his team was creating an ecosystem of apps within the iOS system. So amazing technologist, innovator, and now at Aura. And so let's dig into a conversation, just understand like a little more about sort of like where you've been and what you're doing. But let's start with what you're doing. So I know Aura it's a ring. You want to show everybody? And
You've all seen a ring before.
Right? It's a hardware device that has no screen, and that measures things. And so let's just start like, what have you learned about your own health and patterns, and like how has it changed your approach wearing this thing and getting this quantify itself feedback 24/7?
Yeah, it's interesting because the Oura Ring was not my first wearable device. I actually got the very first Apple Watch when it came out in 2015, I think. And so and before that, I had the Pebble smartwatch. If you're familiar with Pebble, which they actually have released it again, and I got the new one. But like way back before the Apple Watch, I had the Pebble, and so I've been doing this a little while. And I was actually quite skeptical of the rings. Like, what is it going to do that my watch isn't already doing? And when I did get the ring, I was, curious, and I put it on. 6 weeks later, I got a notification in the Apple Health app of all places that said there's been a change in your sleep trend. You're sleeping 45 minutes more per night. The only thing that had changed was I got the ring. I had been wearing the watch, and I was one of those crazy ones who was actually wearing the watch to bed. Most people don't actually wear a wrist worn device for lots of reasons, either because they need to charge it or because it's just uncomfortable to wear. So I was even doing that, and it had not changed my behavior. And so that actually caused me to kind of look at, well, why? Why did that change? What was the difference? And what I realized was Aura had done a really good job at distilling the complex information into a score that I looked at every morning. Like, what was my score? And it might seem maybe a little counterintuitive. It's like, why do you need a score to tell you how well you slept? I mean, don't you know how well you slept when you wake up in the morning? And the answer is that it's actually much more complicated than that, because depending on when you wake up in the morning, like what phase of sleep you're in, you might actually feel very drowsy, but you got enough sleep simply because of the phase of sleep you were in. And so it's not always a good predictor. But when I had the score and I knew, well, first of all, I want that score to be higher, like bigger number is better. Um, that actually, from a behavioral perspective, motivated me to get to sleep earlier. That the watch didn't do. The watch just like, here's some sleep data. Um, and then there were a few other pieces there, but it made me realize that even though Apple has had the rings for a long time, the rings have served as a pretty powerful behavioral nudge as well, like close the rings. Um, it that wasn't all that was needed. Um, and the thing that surprised me was that the form factor actually made the biggest difference, because the watch is great, but if you don't wear it, it's not going to do you any good at all. And so when I was sort of exploring Apple versus Aura, there were a number of things that I started realizing. I think I had blinders on a little bit in my skepticism. And first of all, the form factor means you can sleep with it 24/7. The fact that there's no screen is also indicative of the fact that it's not going to be as distracting, but also it lasts a week on a charge, unlike your watch, which is a day or two if you're lucky. There are some other devices that last a little bit longer. And so every time you take off the device, there's an opportunity to not put it back on again. So that's important. But then the other thing was, and this was the most fascinating and probably intuitive to all the clinical folks here in the room, is that you have two arteries that run along the bottom of your finger, actually called digital arteries. Digital as in digits, not digital as in electronic, of course. And we've done internal measurements where we took the same exact sensor, measure the finger, measure the wrist. And of course, the wrist is mostly capillary flow. It's like your arteries on the other side of like your ulnar and radial arteries are over here, whereas you're measuring on wrist. And so the signal we would get from the ring was between 10 and 100 times stronger, which blew us away when we saw the numbers. Like, we looked at the numbers, and the wrist numbers were like this line that barely had any spikes in it at all, compared to the ring numbers that we were seeing that were just massive. Um, and so that has influenced a lot of the accuracy and so the fact that someone wears it 24/7 and they have more accuracy has had a huge impact on some of the things we can do that we can talk about later. I'm already even talking too much, around detection of conditions like symptom radar, which was developed during COVID, or our recent blood pressure feature and sleep feature, which basically detects sleep apnea. The more data you get, the better those algorithms can be. So that was what motivated me to say, yeah, like this is actually worth it. We can make a bigger difference here. And then the other one that was helpful was that, as a clinician, if I'm going to provide something to someone that helps them improve their health, I want it to be accessible to everyone. Um, Obviously, iPhones and Apple Watches are only available on iPhone, and that always bothered me. Especially if you're going to do programs clinically with payers and providers, like that just doesn't work. And so the fact that it's cross-platform, I think, was a game changer as well. And it just opens up so many opportunities for measurement in a less biased way, and of course partnerships, which is key to growth.
So, do you think the focus on measurement Is that healthy for people? Do you think it's healthy for everybody to be, checking constantly on this, or is it sort of going to divide? Is it kind of like distributed unevenly in the population?
It's definitely distributed unevenly. I mean, you all have probably heard the term orthosomnia. It's like basically you're so worried about your sleep that you don't sleep as well. And that happens. There are people who, probably very type A who are, looking at the data kind of obsessively, and that's not good. We don't want that. And one of the reasons I like our approach is that we don't make more money if you use the ring more. We don't make more money if you open the app more. Like you buy the device, it's a fixed cost. Like to use the device is a fixed cost. Like we're not vying for your attention. And so we don't have an incentive to get you to be obsessed about it. We want you to improve your health. That's the goal. And if we can do that in a way that is appropriate for your level of attention, what is appropriate for you, that's what we want to try to do. And so there are people who obsess way too much, and it's not unique to Aura, like any wearable. And many of them realize I just need to stop, and that's fine. But the thing that I've come to realize is, I mean, many of you have used a stethoscope, still do. That's been a symbol of medicine for over 100 years. Is that the clinician has a stethoscope? They use it to uncover the mysteries inside our body, something you can't see, you can't palpate, you can hear it, and so it uncovers those mysteries. And if I project out into the future, and you were to ask me, would you rather have a stethoscope or a device like this? The answer to me is obvious. Something that can measure your physiology 24/7, not for 30 seconds once a year, is going to change how we approach what we do and what we can do for people. And so the idea that we can be more proactive in alerting individuals to things that are going on that are otherwise silent, like high blood pressure, like sleep apnea, like AFib, like many other conditions we can talk about, like that's the future. And if we want to really bend the cost curve in medicine, you need to think differently than how we've been thinking about just billing more. And I mean, we're here because there's a health system that is bringing in revenue, of course, right now. But I don't think anyone would disagree that our health system is broken from a financial perspective, and we have to figure out how to make it sustainable. And so I think wearables can be a component of that. It is not a panacea, but we're going to see devices like, I mean, this is just crazy. The size of this thing and what it can measure, I'm still like just in awe. And technology like that are going to change, I think, how we think about approaching medicine, especially prevention and screening.
So you get the interval measurements between visits, which we think of as the health data, often from a health facility centric view. But of course, that's not really the health data, right? So we have this opportunity to follow people. And are you engaged in any interesting partnerships where you're following people for sort of medically centered conditions, as opposed to kind of personal health objectives, where you're doing medical monitoring in collaboration with health delivery systems?
We are, yeah. One of the partnerships that we spun up almost 2 years ago now was with Essence, which is a Medicare Advantage plan in the Midwest US. They're actually owned by a tech company called Lumeris. If you've heard of Lumeris before, they actually have a number of health systems, an insurance plan, and they were very interested in understanding, can this device screen, can it help improve outcomes both from a health perspective and a financial perspective? So initially, this was early 2025, so at the beginning of last year, they started making the ring available as a covered benefit. And so any Essence member, and this is MA, of course, so 65 plus, they can say, yes, I want the ring. They'll get it for free. They can kind of help them set it up, and then they wear it. And so the initial year was sort of establishing that baseline. And now what we just launched with them a few months ago was a program where the ring will basically screen for sleep apnea. It won't tell the individual because that would be a regulated feature, but it sends that information to the Essence physicians who are helping to care for that person. And then what they do, and this is a Lumeris, like their AI agent is called Tom, and Tom will actually reach out through a phone call and using voice AI will conduct the Stop Bang survey, which is a validated clinical survey to screen for sleep apnea. If both of these screens are positive, both the ring, the sensor data, as well as the survey, then those individuals get flagged. Essence physicians will reach out, schedule a, a meeting with them, of course, and then a clinic visit, and we'll then get them in for a sleep study, likely where it can be confirmed and a treatment can happen. The reason this is so interesting to Essence, an insurance plan, is that their internal data show that for individuals that have diagnosed sleep apnea, the cost to them per year is about $2,000 or so. For individuals with undiagnosed sleep apnea, when they look retrospectively at, prior to diagnosis, they cost 3 times as much. So they have a vested interest in both improving health and saving money. Like when you can find aligned interests like this, that's great. And so they're very interested in getting more people diagnosed so that they can get them on the right treatment so they have reduced comorbidities. And of course, we want to measure all that. We can't assume it's just going to work. And just because they have this retrospective data, and so we're actually going to be doing a study with them to measure the efficacy of all of these interventions. So excited to see where that goes. When I joined Aura, I said, my goal should be, as a chief medical officer, to build trust and credibility within the organization, both internally for the employees, but also with our partners and externally. And part of that means we need to measure what we do, and we need to publish those results, which I know I'm preaching to the choir here, but as you've probably seen, not all wearables have a goal to publish all of their evidence to be transparent. So we're trying to build that muscle right now to make sure we can do exactly that.
And so as you are measuring, and that's great that you're measuring and reporting out so that we understand the utility here. The buzzword that has to be included as an obligation in any grant or talk is multimodal. So what are your favorite pairings of your data with other data sources?
Oh, it's a good question. We did not arrange any of these questions in advance, as you can see. So I'm like, what would be my favorite pairing of data? I mean, this is sort of a cop-out answer because that's what I've been spending almost my entire career doing. But bringing in EHR data is still very, very important. And it's what we did at Apple. And it's actually it takes a little bit of time to build that infrastructure and build the partnership. So we actually partnered with FlexPA, who is doing that as well, a third party who they're integrated with health systems, with payers, and with TEFCA infrastructure. And this is important for a number of reasons. And again, I'm preaching to the choir here, but it's important to understand the ground truth of risk for an individual. But it's also really important if you're going to build algorithms to understand what that ground truth is, not just from a user experience perspective, but also an algorithm development perspective. And so really excited about that, piece. But also I think the underappreciated data stream is getting direct feedback from individuals. So you can call it PROs, whatever it is, surveys, but asking people directly. And of course, you do this in studies all the time. You collect that feedback. But we have done quite a bit of that. And we actually did a study about a year ago. And study is light. Like we called it a heart health check-in, basically a really simple questionnaire where we collected some basic demographic information. This was before we had health records integration, and we captured some of their medical history. We actually used that to develop our blood pressure feature, where we can determine if someone has high blood pressure or not, with a specificity about 90%, sensitivity about 60, which sounds low until you realize that Apple's hypertension notification has a sensitivity of 40%. So they're not detecting all cases. And that heart health check-in, we got 450,000 people to do that in 4 months. Crazy. And this was when we were a third the size of a company as we are today. And so the appetite for individuals contributing back is pretty mind-boggling. And so we've done some additional studies since then, also hundreds of thousands, like with these surveys. And and so we're currently exploring how do we really scale that. And my dream would be, can we launch a much broader type of study, and get over 1 million people engaged, which, given what we did when we were less than half the size, if we had a big marketing push around it, no doubt we could reach 1 million people. Um, and the thing that would make me most excited isn't just what we can discover with that, but it is how do we help return some of the results directly back to the individuals, which I think has always been a limitation of these large scale studies. Something I wanted to do at Apple and which is so hard to do. Every once in a while, if you participated in the research app studies, there will be, hey, here's some results, but it's like once a year or something. But can we really give people much more transparency in terms of how their data is being used and what's happening with it? And I think that would be really fun, to do something like that. But I got off on a tangent a little bit, but hopefully it was a useful one.
So we think about like sort of, let's just think about the safety side for a second. So you mentioned Apple hypertension's 40% sensitive. So that's probably an issue, right? Because
the FDA approved it.
Yeah. Right. And so you, if you're worried about your blood pressure, it's probably because you have high blood pressure. And so if it's telling you you don't have high blood pressure right now, that's probably reassuring in a bad way. I could imagine, and I'm just riffing here, but that if you didn't have atrial fibrillation and it was going to detect atrial fibrillation 40% of the time, at least 40% of people would get alerted that they've got a new problem, and that's a net positive. But so these things really make a difference.
Yep.
And then the regulation of wearables has come under some controversy with Whoop and with decisions and reverse decisions. How do you think about this? Because in some ways it would be great, I would imagine, for Aura to have FDA approved medical devices. On the other hand, it brings up some of these other issues. How do you guys think about that?
Yeah, I think when we talk to clinicians today, they ask for the data, which that makes a lot of sense. For many clinicians, they don't have time to go through the accuracy data that like we've published and that others have published. They need a shortcut. And for most of them, the shortcut is it FDA cleared or not? Like that's the shortcut. So it's still going to be necessary. It's still important for the future. But the way we think about this, as you probably know, the FDA issued updated general wellness guidance in January of this year. And it was the first time it had been updated in 7 years. It was updated in 2019 and then early 2026. And that guidance actually did a couple things. Like technology's changed a lot in the last 7 years. So I think it was warranted to have updated guidance. And one of the things that they said we can now do is you can give a notification to an individual if you've detected a condition of some sort. So very similar to many of these other features that have been FDA cleared. But in this case, they said you can do it without clearance, with one major caveat. I don't know if anyone here knows what that caveat is. I'm not gonna call on anyone. But the caveat is that you can't name the condition. So you can give a notification, for example, that we've detected hypertension. You just can't say we've detected hypertension. And so we think that's a little bit weird. We think it's still an opening, and why we've actually released a couple of features saying we're tracking your blood pressure. We can't say hypertension. We can't say high blood pressure. We can say blood pressure. We can say we've measured something there. We can say now you should take your blood pressure with a cuff twice a day for a week and then go talk to your doctor. We can say all of those things. And so at the end of the day, sometimes sensitivity is going to be low, sometimes it's going to be higher. The goal is, how do we help people improve their health? How do you help them understand that something might be going on that is otherwise invisible to them? And I think that's why the FDA supported a sensitivity of 40%, because that's 40% of people that have high blood pressure that otherwise wouldn't have known. And that's okay. And you still have a responsibility to create the feature in a way that doesn't overpromise if they don't get an alert, to Ken's point. A negative result does not mean you don't have high blood pressure. And so part of that is user experience design, as we experience right here, like build the user experience that is going to help people get to the right outcome, create the environment that will encourage that. And so we have to think about that all the time as well. And how do we create that right user experience? But at the end of the day, we think that there's a whole suite of screening type features that don't diagnose. They raise awareness that there might be something going on. Go talk to your doctor. And you've probably seen as well that we're in this weird world, especially post COVID now, where there's actually a lot of distrust in healthcare generally. And so a lot of people are seeking alternative treatments or something other than going to talk to their doctor. And so I actually feel like we have a responsibility in many ways that for people who have checked out of regular healthcare, that there are opportunities to say, hey, no, you actually need to check back in and talk to a doctor because this is something that only they can help you verify, validate, and get the appropriate treatment. And so I think there are many cases where we've helped people to do that. And I think that's one of the roles that wearables can play is raising that awareness. Because what we've seen is people trust us an incredible amount. Like I'm surprised at how much they like just trust the device. I think there are a lot of reasons for that that we don't have to get into now, but partly because when it gives them a number, that number generally reflects how they're feeling and how they think about themselves, and it changes in accordance with again how they're feeling. And so the trust is built up over time. But once they have that trust, I think that's a huge responsibility on us to use that trust in a way that helps continue to improve their health.
So I forgot to mention your most important characteristic, which is that you're a pediatrician.
Yeah.
Okay, so there's a lot of folks here. Everyone here is working in a pediatric hospital. We've got folks on Zoom too. We have interns, postdocs, faculty. So can you talk a little bit about your journey in from just taking care of kids into this world of high tech?
Sure. Yeah. So I did my residency at UNC. So I'm med peds. So I don't know if that like brings me down a notch in your eyes. So not a pure pediatrician. Well, actually, no. I'm a full pediatrician and a full internist. So I'm gonna claim both. Also, clinical informaticist. But my general inclination was always on the pediatric side. So I actually worked as a pediatric hospitalist when I was at Duke. I did medicine for a little bit, but then once I started doing more informatics, I couldn't do both. And if I had to pick, I'm going to do pediatrics, not medicine, which is again, hopefully I've redeemed myself for you all. There are a lot of reasons why we've chosen to go into fields like this, and it's actually an interesting area, especially for wearables, because many wearables aren't quote unquote designed for pediatrics. There are some wearables out there you see like the owlets, and which you might actually see as somewhat controversial as well, like the baby monitors and over alerting. So we have twin daughters. They'll be 21 later this year, which is crazy. They grow up fast. But when they were born, they were born at 37 weeks. Actually, long story short, they had some apnea prematurity, and so we went home with a baby monitor at the time before all the technology-enabled ones, and it was beeping all the time. And when we eventually took it in so they could look at it, they were all false positives, every single one. And so I was like, this is a net negative for our quality of life. But I get it. I get it. And so even the devices that are out there are somewhat controversial for kids. And like, is it just a play to build a company and generate revenue, or is it actually going to change care and improve quality? And I think it's moving in that direction, but we're actually limited because a lot of these devices aren't approved for kids, including the Ring. I think there are like teenagers, middle school age kids that wear it, but a lot of the features are not validated in that population. There's a lot of work to do there. Obviously, as a pediatrician and as a father, I would love to do more work in that space and figure out how we can continue to move that needle. But we need to do the science before we can say, hey, let's just open up the floodgates. That would just be a cash grab, and no, we're not interested in that. We're interested in how do you actually move the needle. And the area that I think is most interesting, especially for wearables, is So we've done a lot of work in women's health and in pregnancy. And so if you could extend that to, we're not going to be putting a ring on newborns anytime soon, um, but looking at the parents in the post birth environments and in the few years after that could be really interesting. And then of course, once children get old enough, helping like things like milestones and all that, it could be really really interesting. But right now, our focus is on adults. Sometimes to my chagrin, but there's a lot more work that needs to happen there.
So talk a little bit about the women's health work, because that is one of your in-depth areas.
Yeah, so we several years ago we actually started up a partnership with Natural Cycles, which you might be familiar with. It's the first FDA cleared non-hormonal contraception, and I think there was a little. Even that is a little bit like it's not as accurate as other forms of contraception, um, but many women don't want hormonal contraception and they're looking for other options. And in order to do this well, it has to be paired with a device that has accurate temperature. That's a key part of the non-hormonal contraception. And prior to the Aura Ring, what women were doing was measuring their temperature manually once a day, which that's not a fun way to do it. It's easy to forget. And then as soon as you forget, don't log it, then the accuracy of the contraception goes down, and you don't want that either. And so we partner with them. You can wear the ring, and it gives you consistent temperature 24/7. Well, when you're sleeping every single day, and so compliance is actually better. And so that actually brought in a lot of people to start using Aura, and they came for the natural cycles, and they stayed for everything else that's there as well. So we now have fertile window prediction, which is actually a registered FDA Class 1 device. And we've actually tuned a lot of our algorithms, especially around sleep and resilience, the scores for pregnancy as well, because the physiology during pregnancy is very different, as you all know, than when you're not pregnant. And so there were a lot of alerts saying your readiness is low. Other things, well, of course it is. Um, but then also we have started doing a lot of work in menopause and perimenopause. We actually just created, and I think the team's working to publish a new what we call a menopause impact scale, so a new survey, which we have validated internally to determine if someone is in premenopause or menopause, because the previous surveys that are out there, like you have to pay money for, and they're harder to access from a licensing perspective. We just wanted to create one that was more open. So we're doing that, and then most recently, we actually built an LLM. We're fine-tuned a model for women's health. So we have what we call our Aura Advisor, which is the AI agent within the Aura app, has access to all of your data, so it can answer your questions, give you feedback on the data that's there. And we saw a huge gap in the accuracy of the data that it was providing on women's health issues. And it was we were using a large foundation model that all of you have heard of, for that, and it just wasn't doing a very good job. And so we fine-tune our own model by, hand selecting the highest quality evidence. And now the results are much, much better, according to our internal evals, which I'm pushing the team to publish more publicly as well, which is so important. We actually did put up a blog post that talks about our process for how we developed it and how we conduct our evals. And so I think we're going to see more and more of that. Some of these custom models, Ken and I were actually just talking right before this, that apparently we're reaching maybe a little bit of a plateau in the foundation models, not because the technology is slowing down, but because the government doesn't want us to have better models because of the risk potentially, which is really interesting. And so I actually think that may open up some opportunity for custom models that don't do, that aren't good at hacking and everything else, to be really good at one or two things. And clinical models, I think, are going to fit that mold. And so I think we're going to start to see higher quality clinical models, both trained with better accuracy, but also accompanied with a RAG-based approaches. And many of you may have seen the paper that came out last week around the latest update to I forgot what the benchmark was called, but it showed that the top four models among a large list of models that were all benchmarked clinically were all RAG-based models, and all the others were like all the foundation models were much less accurate than the RAG-based models. So I think we're going to see more and more of that.
Nice. So I want to, everyone should think about questions you have, and you can start to raise your hands, and we'll get microphones out to folks as you think of questions. And while you're thinking, so tell us a little more also just about that career transition to like how did you decide, for example, when Apple tapped you on the shoulder that you were gonna, go into this very, very different environment?
It is a very different environment. And, as I was contemplating that, of course, people would joke, well, you're going to the dark side and all of those things, which I'm sure you've heard before. The way I approached it, and maybe to go back a couple steps, I did not major in computer science. If I knew then what I know now, maybe I would have considered it. Although both my children are now majoring in computer science, and I have no idea if they'll be able to get a job when they graduate. So who knows? We'll see. You all are highly specialized, and if there are any trainees here, you're not going to have any problem. But I was interested in technology and trying to bring healthcare and technology together. And I actually started, it was in 2009. So I started residency in 08 and 09. I got a couple books on Amazon on how to build iPhone apps and write in Objective-C, which was the language used for iPhones at the time. Because when the iPhone came out, it was just obvious that we're all going to have computers in our pocket pretty soon. And I thought that was, something I wanted to learn more about. So at that point is when I taught myself how to write iPhone apps, released several in the App Store, ended up starting a company on the side during my residency. This started during my PICU rotation of all places. Not because I had a lot of free time, but because when I got home, I needed a way to unwind. And for me, that was using a very different side of my brain than I used at the hospital. And so it was relaxing to me. And maybe some of you are similar, but otherwise you can laugh at me, that's fine. And so that kind of started this journey, and like, how do I combine healthcare and technology together? And so I started reaching out, to various folks, and ended up doing what we call a special month during our MedPeds program at Vanderbilt, which was one of the National Library of Medicine certified informatics programs. This was before clinical informatics existed as a fellowship program. Spent a month there, just loved every minute of it. Both the academic environment, both building and studying. I was able to build some things when I was there. And then I spent some time at Duke with their informatics program, as well as UNC. And my inclination was less the research, and it was more like, how do we actually build things that work for people? And so I think that's why I had an opportunity to join the faculty at Duke after my residency to lead mobile technology strategy. And part of that was Duke had just gone live on Epic. UNC was not yet on Epic, although they were working down that path. And I felt like I could hit the ground running if I started at an organization that already had Epic, and I could start building against that. So I got to Duke, did the physician build trainings, going to Verona, Wisconsin, and did all of that, so I could do anything I wanted within Epic and started building things. And of course, we built an API that was JSON-based, REST-based API. And then when I learned what they were doing, it's like, well, we don't want to reinvent the wheel. Like, let's just do that, like, because they already had the FHIR specification. So back before anyone knew how to pronounce or spell FHIR. And I think the way the story goes, you can correct me if this is wrong, but I think you were already talking to Cerner and Athena Health, and you didn't have any contacts at Epic. And so maybe that's false, I don't know, but we were doing this with Epic. And so we ended up actually giving joint presentations with Cerner and Athena Health at national conferences like HIMSS and others, showing, hey, this could work on Epic too. And then we told Epic, like, we don't want to support this, like, you all need to build it, and had a great relationship with them where they kind of took it in. And then Argonaut, Project Argonaut,
Mm-hmm.
got spun up and to kind of make it official. So that all happened, and that was, I think, when I was at Duke, that was one of the biggest things that I was most excited about because I was just trying to solve my own problem. How do we liberate data from the EHR so clinicians, patients, and researchers can have easier access to it? That was the goal, and so I wanted to fix that problem, and of course, building on all the great work that you all have done here. And so when Apple came knocking, it was a natural progression. If I wanted to take what we had done and expand it to even more people and actually build something that is tangible that others can use and benefit from, for me, that was like a no-brainer. Like we need to expand it. And even though Apple was iOS only, which was always a little bit of a limitation, I felt like the influence that we would have there could help push the industry forward. And the thing that I'm probably most proud of from my time at Apple is that we were able to, so they actually had a very different plan for how they wanted to get health record data when I joined. And I said, no, 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 we need to do it using open standards for lots of reasons. Health systems aren't going to want a proprietary system, and open standards will, I knew in the back of my mind, would make it available to other platforms by default, which was so important if we want to reach all patients. And so when we helped to build this kind of first set of infrastructure, which meant we were working directly with health systems, directly with Epic, Cerner, Athena Health early on, I knew that if we did this well, others would be able to come in and use the same APIs. And of course, now with AI and all the LLMs, we have lots of companies that have sprung up, all using the same infrastructure. And like, I couldn't be happier that that's the case, because my goal was never to like just do something for one segment of people, but for everyone. And I mean, I have to say as well that it's absolutely a team effort. It wasn't me doing this alone at Apple. We had an amazing team. There's still an amazing team. Pascal's still there, and still tons of work that has to happen in this space. I've been on ONC task forces as well, building this and continuing to iterate. There's still so much work to do, but it's okay every once in a while to look back and see, okay, we've made progress. Let's keep pushing forward.
And just to put a fine point on that, what happened was it came a regulation that said you have to have patients who can get their data in a standard form across an API. And that's all the regulation said. We wanted the regulation to say it had to be smart and it had to be FHIR and it had to be smart on FHIR. But they felt these technologies were too immature. So we cohered this group called Argonaut. It's a pun on JSON. And Ricky became part of that, and the EHR vendors. They had to choose how they were going to comply with the federal regulation. Regulations can be powerful things. And we had Smart on FHIR, open source, free, Apache 2 licensed, commercially extremely friendly. No obligation on the part of the user to do anything for us whatsoever. Companies had taken what we had done and made proprietary versions, which put obligations on the end user or costs on the end user. And this is where open and free won, because it was just a decision. Those guys made their own decision. And it happened. And so that meant that all of a sudden, Epic and other EHR vendors had to have endpoints of FHIR that were accessible by Smart on FHIR. But there's no way they're going to work well until there's a demand signal. And I wasn't aware when Ricky started this, as this was all NDA stuff with the different hospitals, but I became aware that they had gone to some number of 100, 200 hospitals or something, and gotten them to make these endpoints really work. Because Apple can't have lousy, poorly formed data showing up on people's iPhones, right? It's not the brand. And as Ricky was saying, this was not really Apple's DNA to do something in an open way, where an Android device could come in and take advantage of the work that Apple had invested in. But that's exactly what Apple did because of Ricky and team. And now, most recently, all the language model companies have opened up their platforms to enable patients to bring their data in using smart on fire, and it's using all those same endpoints were that were that were made into sort of full production quality because of the Apple efforts.
And I think it's a great example of the also sequential legislation that initially it was pretty vague, like you said, but they needed to see both the demand signal, but also successful implementation of something in the real world before they could add the smart, and fire aspect to it. And we heard from Don Rucker directly. It's like when we saw that it was possible in the ecosystem, we had confidence that we could actually require this of people, which
Yeah.
sometimes you gotta build the thing and you gotta prove feasibility, which makes sense. You don't want the government requiring you to do things that aren't feasible, that just aren't going to work. And so sometimes you gotta do that work.
You have to be careful of standards efforts that get way far out ahead of the implementations. This was successful because there was an implementation of it. It's very hard to just imagine what the standard should be before you've seen how it actually works in the real world. All right. So it's 3 o'clock. So we will wrap up. And I want to thank you, Ricky. You're a superstar, and you gave landmark ideas very early in the series, in the old times,
The old
before
times,
the
the before
pandemic,
times.
the
Yeah.
before times. And I want to thank you for coming back in your new role and doing it. And we hope to keep in close touch. And I know you're going to meet with the trainees soon as well. And I'm sure people here can, as we close down the Zoom, ask a few questions as well. We have a next Landmark Ideas is Michael Howell, Chief Health Officer of Google, is coming in September on, I think, the 15th. So we hope to see you there. And thank you very much.
Thank you. Always a pleasure to be here. Thanks for the great questions.